it goes. So here we've got I hope you can all see the timeline on the screen now. It's just a little graphic showing where we've come, where we are now, and what we've got ahead of us. So you can clearly see we're sort of nearing the end of the study. We've done the main, all the data collection, and we've just locked the data. And so next coming up, we've got the validation, various analysis, and then we have the 1-year follow-up as well, and results, etc. So if we move the slides, Savesh. So this is a little screen just showing how well we've done. I think it's a big thank you to everyone for being involved and for just working so hard. We've worked hard, but we appreciate that everyone involved has worked hard, all the national and hospital leads. And we've done amazing to get over 50,000 patient records. I think that, we didn't really think we'd get so much. That's so quite impressive. And this is a little map just showing the countries that we're in. So everyone, go to the next slide. Just some more information about where the data is coming from. And you can see at the bottom there, we have very little missing data. So actually, I think that's really good. And just before the data lock, we've done brilliantly and you've all done brilliantly in pushing to get all that missing data down and to get the completeness as high as possible. So that's really, really good. Next slide, Savesh. And again, we got some friendly competition, I guess. I don't know. We've got a little the sort of scoreboard of countries and also groups. So on the left here, we've got the individual center. It's hard to, I guess, tell the actual name of these centers through the codes, but we've got the country code there and then the hospital codes. But well done for everyone and all the countries and all the hospitals that have put in so much work. Yeah.
So thank you very much, John, and thanks to everyone who's just joined in since. Like we said, it's been great to have 50,000 patients and really exciting next steps. So without further ado, I'm going to welcome Dr. Rena Pius, who's going to talk to us about data validation and the next steps for GECKO.
Thanks very much, John and Savesh. Hello from me. Hello, if you haven't met me before, I'm a senior data manager working on GECKO, and I am looking into data quality and setting up the validation study. I'm thoroughly blown away by the number of records, and more so, I'm so surprised by the high quality of the records. So we don't just have a high number of records, we have a really high quality within it. I'm not going to volunteer any specific numbers on the quality just yet because it's preliminary and the checks are ongoing. However, I can assure you that the data is looking very high quality with just a small percentage of the 50,000 patients seeing incomplete variables. So we are going to do the validation part of the study. The validation is going to run in February. So accounts to validators will be sent out early February, and they will have to complete everything by the end of February. Validation in this context has two purposes. One is to assess data accuracy. So that's for each patient. If the record says they're 55 years old, are they really? If the record said they had open surgery with this complication, did they really, or did they have a laparoscopy? So the data accuracy within each patient record. And the second part of validation is ascertainment. So do we have the number of patients who had surgery in that 2-week period, or were there more patients who didn't get entered into the study? And that's ascertainment, how many patients of the total we have recorded. All high quality publications must report these two validation aspects, data accuracy and ascertainment, and also they have to be done by an independent assessor to be able to consider for publication in high quality journals. Once we run the validation in February, by the end of February or March, we will not remove any of the data entered last year. That's not the methodology of validation. So even if a center, the validator says, by the way, quite a few patients were missed, that's fine. We will report this honestly in our paper. We say this many patients were missed. This is the accuracy. We will not modify the original data. That's not what validation does. So anyone who passes through the initial data quality checks pre-validation will be included in authorship and the final write-up, and the validation is just to describe the accuracy, not to change it. And as an example of a previous high-quality study we ran, Global Search 3 was looking at outcomes following cancer surgery specifically. And the validation part of the study showed good and very good accuracy, as indicated by kappa values. And we had a 96.4 case ascertainment value based on validation. And we were able to put these two kind of facts into the paper that we published in The Lancet. So how do we validate? The hospital leads register one independent validator per hospital. So it's not one per period, it's one per hospital. And independent means they can't have been part of any of the data collection teams. The validator will only be asked to validate a single 2-week period. They will not have to validate all 8 of them. The single period is chosen by random by the system we've set up here. Validator account, RedCap accounts will be emailed out at the beginning of February. And once they log in to RedCap, they will find 2 projects called Stage 1 and Stage 2. And as I mentioned previously, these refer to Stage 1 is accuracy and Stage 2 is ascertainment. And both stages will be must be completed by the end of February. It's a leap year, so you get an extra day. And they can be completed at the same time. You don't need to submit Stage 1 and wait for our approval. No, you can do one after another. And now I'm going to run through a quick RedCap guide of what it looks like for validators, because I'll admit, even though validators are only asked to submit a small handful of data points, they have to do it in 2 different places. So that may confuse you. So these slides obviously will be shared as PDF guides, and you will have them as reference once you set up your validators in your hospital, so you can pass them on to them and we will pass them on to them. So don't worry about taking screenshots or anything like that. Just enjoy the journey of RedCap that will be presented to you. So once the validator logs in, they will see 2 projects, Stage 1 and Stage 2. Once they click on Stage 1, they'll see this generic RedCap screen that says, the name of the project and some options. They'll then click on the record status dashboard, where there will be a point for each patient within their randomized validation period. So they will have to click through every patient point there and have a look at the content and see how they can validate it. So at the top of, so I've now opened up a single patient point. One of those, I had 2 points as an example, but you will have as many as was in the period. I can tell you that most hospitals perform 10 or fewer cholecystectomies in a 2-week period. So most validators will see around 10 or fewer patient points. The validators are only asked to look up these 1, 2, 3, 4, 5, 6 variables. They will not need to enter the whole set of that the collaborators were, but the collaborators were working as a big team, not alone. So this is fair. The validators are provided with these values: age, gender, indication for surgery, operative approach, and mode of anesthesia. Now, because we didn't collect personal ID numbers, for information governance reasons. These are the only values the validator has to go by to identify the patient. So I would recommend that the validators look up all patients who had a cholecystectomy in their 2-week period, and then order them by age. Then look at the age, then match the gender, and then match the operation time. And you should be able to identify. Like I said, most validators are looking from a pool of 10 patients. So within 10 patients, these variables should be enough to identify the patient. The validator is then asked whether any of these variables seem wrong, so they could correct the age. There were like only one 30-year-old woman had surgery in that 2-week period. They must have been 30, not 34, for example, so that they can enter a correction here. And similarly for the other included variables. Once they've done this screen, the identification and correction screen, there's one last part to this accuracy stage, and that is entering 6 more variables, and that's the urgency. Was it elective, delayed, emergency, the Clavie and Indo complication grade, and then there's a few more questions that didn't fit on this screen. The validator will enter these values. And they should set the complete form complete. And once you set the form complete and then do save and exit, the dot will turn green. So remember, when you logged in, the dot was red. It turns green automatically once you set the fill the form and set it complete. So the validator must go through all of these patients, fill in all of the information, set them, make them all green, and that's stage 1 done. They should then go back to the RedCap login screen or the project screen and open up stage 2, which is about case ascertainment, aka missing patients. They will only see a single line. They will see a single line with 2 dots on it. So they will not see 10 patient points. Single line, because it's a hospital level record now in ascertainment. They will open up the first record, and there are just 3 questions. The 3 questions are, what's the most reliable way to identify patients? And there's a drop-down menu of whether it's a theatre logbook or a logbook or electronic record, and so select one. And second, what's the most accurate method for follow-up? Again, there's a drop-down. And finally, the third question is, do you think any patients were missing? So if you were presented with 5 patients, but you can see from the theatre logbook that 10 had surgery, you then need to say yes, 10. In this example, I've said that 2 patients are missing from the database or the RedCap database. So I've entered number 2. I've set this to complete, and then I'm going to save and go to next form. We will then ask for some basic demographic information on those missing patients. This is important because then we can report that whether there are patterns in the missing part of data, and this is really important. So whether the missing patients are in general more likely to be emergency cases, are they more likely to be, I don't know, older, or this is something we need to look at. So this is the basic form for missing patients. So in my example, I said 2 patients are missing. I will then enter these values. Again, this is a small subset of variables. This is not the whole list of variables that the original collaborators were asked to enter. Yeah, 6 basic variables. And now this is the trick of it. Are there any more patient values to add? So yes, I said I have to add 2 patients. So to add a second patient, I need to click here, save and add new instance, or alternatively, I can go back to the record dashboard and then press this plus button. So both of these screenshots are embedded into RedCap, so you will not need to memorize this, but I'll mention it anyway. So this is, you will be adding, this is how you'll be adding a second patient. And once you've added a second patient, for example, I filled in the 6 basic variables for the second patient as well. If you then click on this kind of pile of green dots, you will see 1, 2. So 1, 2 missing patients data have been entered. And so to finalize, this is stage 1 on the left. So you will, RedCap will present you with as many red dots as you had patients. In stage 2, if there were missing patients, then it might have been 0. So maybe all patients were already included. But if there were missing patients, you must create green dots for each and one missing patient. Stage 1, stage 2. Thank you. So I will, trying to go back, sorry. I will look at the questions now about validation now. Yeah. What happens to periods when no patient was recorded by, should it be considered as a missing data for that period of data? So periods where without any patients will not be included in the study. They will not be included in the randomization, and they will not be presented to the validator. But that's a good question. It does happen that no patients had a cholecystectomy in a 2-week period. What if there's a missing patient outside the randomized period assigned? So if you think there's a missing, so the randomized period is defined at the beginning of the stage 1. So as a validator, you are only asked to enter patients from, say, the 1st of August to the 14th of August. If you think there's a missing patient on the 20th of August, which is the second period or whatever, ignore it. So the validation defines the dates quickly. The validator should only worry about the dates presented to them by RedCap. Anything out with those dates is not their problem. What if we realize there are mistakes in RedCap record other than the one assigned to the validator? How can we correct those? Data will be locked. Data has been locked this week. We have given a small handful of extensions until Monday. So if there are any mistakes by Monday, they can't be fixed. Thing is, mistakes happen. I make mistakes when I enter data. And that's why we're running the validation study. So the aim of the validation study, when we go to publish this paper in the Lancet, I hope, the aim isn't to say our data is 100% accurate, because that will never be, no one will believe that. And the study claiming that will not be published. We want to honestly assess the accuracy. And if a few mistakes are there after the data has been locked, we will just be honest about that. And that's absolutely fine. Our health network has 4 hospital campuses. How can one validator be used for all? Yes, that's a really good question that comes up. That has come up previously with different departments and different logins. The best thing is to email Sivesh and myself, and we will figure this out. We'll make sure that the validator is assigned a period from a campus they actually have access to. And we will advise you on whether this hospital classifies as multiple different hospitals and you need 2 validators, or whether we can, yeah. So that's quite a special case, having just said that we have seen this quite a few times before. So email us. Sivesh, is there anything you want to add about that?
Not very much, Rina. Thank you so much for the presentation. I think it's been really in depth. I think one question I had that I think keeps coming up quite a lot, but probably worth re-emphasizing, is who can be data validators? Because sometimes we get questions from national leads who work in certain hospitals, or hospital leads themselves, or collaborators. Who should be data validators, and why is it really important for us and for the study and for the data, who it should be?
It should be a person who has the relevant access to the data and the hospital log. So for example, we have had a senior year medical student validate the data set, but because that student had already done research before, they already had access to the theatre logbook, they had access to the medical health records, so it's fine for a medical student to do it. However, in most cases, we would expect it to be a doctor because they are more likely to have the appropriate access and the appropriate kind of oversight of the patients who had. So it depends on your hospital. It must not be someone who was part of any of the original periods. So even if the validation period is randomized to something different, it can't be an original collaborator. And to answer a related question in the chats, one validator per hospital. So it's one for all 8 periods. They will only validate a single period chosen by random. We don't validate all 8 periods. So that answers that question. Could be possible to extend a little longer the data lockup? We just received the go from our ethics committee. The data will be locked on Monday. I'm sorry, but we cannot proceed with validation unless we lock the data set. So you can write to Sivesh and see how many records you are and see if you can get them in, even if you can get just one period in by Monday. But we can't hold up the whole validation project any longer. I'm sorry. Any other questions?
I think that's all I had. I don't know if any other panelists would like to come in at this point. Ewan, Natalie, anything to add? Thank you so much, Renu. I think for everyone who's just joined, I think that's been a really whistle-stop tour and really in-depth in terms of data validation in detail. Thankfully, we've recorded this, so for anyone who's just joined, who's just missed it, we'll share this video. Thank you so much, Renu. So I think, as Renu has really highlighted, data validation is really important so that we can get good quality data and know what the quality of data is. And I think the next step is about the 1-year follow-up. And again, there's been a lot of questions about 1-year follow-up. When should we be doing it? And if it would affect your missing data. So it shouldn't affect your missing data at the present time. But Natalie will talk to us about what the 1-year follow-up should entail. When can you do it and what it entails? Natalie?
Great, thanks, Svesh. Sorry about that. So hello, everyone. Hopefully you've all found it quite useful so far. I'm Natalie, one of the PhD fellows at the University of Birmingham. Just quickly going to go through what we want for the 1-year follow-up, which will be coming up quite soon. So this will hopefully help us understand more the longer term effects of cholecystectomy. So Svesh, would you mind moving the screen for me, I think?
Yeah.
So for our 1-year follow-up, we will hopefully be able to get the information for all of our patients that have been included into GECKO. And our main focus for this follow-up part is that we want to look at bile duct injury and also gallbladder cancer. And this is for all of the patients that you guys have managed to get into the GECKO study so far. So the reason why we want to look at 1-year follow-up is that this will help us understand more longer-term management of patients that have bile duct injury, and also to understand the information around the management of gallbladder cancers, which usually we're not able to get within the 30-day follow-up. Now, when we complete the form for both for the 1-year follow-up, we want all of the information completed if patients have a bile duct injury, and also if the gallbladder cancer pro forma as well. But also there's a separate section that looks at 1-year follow-up and a part of the pro forma that we also want completing, whether they have a bile duct injury or gallbladder cancer or neither of them. And to be able to maximise follow-up, we want to be able to, obviously, hopefully you guys have kept a list of the patient IDs and the corresponding RedCap ID so that we can identify the patients that have been included into the GECKO study, so that we can find these patients within the hospitals that you're all at, so that we can collect the 1 year follow-up. We also would hope that we can ensure that the local governing bodies and audit officers are aware that this is a follow-up study from the beginning, so that we don't need to, hopefully apply for further ethics or anything like that. And the people that are collecting the data in the 1 year follow-up, that does not need to be the same people as that collected the data from previously, as we are aware that people move from different hospitals to other places. And the ones that want to start joining our study to collect this data, hopefully we'll be giving out some more information to be able to register these new members in the next few months or so. So hopefully we can make this part of our study a success as well.
Thank you so much, Natalie, for that talk. So I think it's really important that we ensure maximum follow-up of as many patients as we can. And I think, as Renu highlighted earlier, the database will be locked for the first 3 forms. So with the preoperative, intraoperative, and postoperative forms. And if some of you, which a lot of you have indicated that there are no cancers, you do not need to follow up those patients for any cancer up to a year, only just a general 1 year follow outcomes. At that point, I can't see if there's any questions at the moment. Natalie or John, is there any questions on the chat at the moment? Okay. So I think, with a lot of collaboratives, it's often useful to think about where we go from here, and it's just not worth only stopping at the data collection point. So I'd like to invite Professor Ewan Harrison to talk about really where the next steps are and where the future of the collaborative is.
Thank you, Sivesh. I'm Ewan Harrison. I'm a professor of surgery and data science in Edinburgh and one of the leads on the Global Surge project. Thank you so much for all the amazing work that has gone into this project. As others have said, you've all done an absolutely phenomenal job at bringing in such a generalizable, broad, globally relevant study. So you should all feel really pleased with how things are at the moment. So we've already started the data analysis, and this will be ongoing during the validation period. So validation doesn't slow us down. It happens in parallel with the initial analysis of the data, which is going on at the moment. So there's a number of stages that we go through next. So I'm going to talk very briefly, but maybe just 3 or 4 points. So initial publications is the first point. So clearly we're looking for a high impact first publication from this study. So publishing in a high impact journal is completely dependent on the message encapsulated in that study. Very little else matters. And that message needs to be generalizable and applicable across the world. So it won't be about the fine print management of gallstones, but will likely focus on something around the provision of minimally invasive surgical services, etc., etc. And we're working on exactly what that message is, and we'll share it with you after that. The second initial publication will be orientated more towards a surgical journal, a surgical paper for surgeons dealing with or performing cholecystectomy, and taking much more to do with the management of the disease, variation in the management of the disease, and outcomes from that. This is an exciting study because we have these 1 year outcomes to come. So we won't be talking about cancer until we have the 1 year data. We will be talking about bioduct injury in the data that we have at the moment, but there'll obviously be 1 year bioduct injury follow-up data. So it's really important that we try and capture as much of that 1 year data as we can, because that would really take this from being a typical, if you like, collaborative study to one that had meaningful long-term follow-up, which is something that all collaborative researchers have struggled to deliver worldwide. After that, then we have follow-up studies, and we've been having some initial discussions about what an interventional trial in cholecystectomy would look like based on the data that we've got coming in from GECKO. You may be aware of the EAGLE study, which is coming up for publication at the moment, which was an educational intervention to improve outcomes after right hemicolectomy. And there'll be an opportunity, for instance, to do something with cholecystectomy. So, I mean, I'd be very interested in your ideas, but potentially a critical view of safety checklist or pause that was introduced to hospitals who don't have it on a cluster randomized control design, for instance. So lots of options there. So initial publications, the first one will be broad, generalizable Lancet level messages, then a further publication with the detail around cholecystectomy, the management of gallstone disease itself. The 1-year follow-up is incredibly important, and we'd really appreciate your ideas on the follow-on interventional studies, which would really change this from an observational study to one providing very high quality data around the management of the performance anyway of cholecystectomy. Thank you so much.
Thank you, and I think there is a lot to unpack there, and there's a lot of exciting opportunities moving forwards for the collaborative, who's been working so hard over the last few months. So at this point, I think to bring in some of the points that Ewan has really highlighted, and following on from Renu's talk, could I bring in Maria and Amanda, who's currently on the call, who've both been national leads for the study, who've been really involved throughout. Can I just bring in Amanda, if you're on the call, or Maria, just to comment about what your thoughts are and experiences so far about the collaborative and some of the future visions that Ewan has painted so far.
Thank you very much, Savesh. Good evening, everybody. I'm Amanda. I'm the national lead for Australia. I'd like to thank, in particular, Rena and Natalie for their presentations. I think they've been very useful. And thank you very much, Ewan, for outlining some of those future directions. I think I can certainly see that there are some of the Australian leads online, and I think it's probably important to consider the planning for the next 12 months in terms of both the validation as well as the 12-month follow-up. Many of our sites, the leads are going to change in the next 12 months as our registrars and junior doctors move to their jobs for next year. And so it's certainly really, really important to have that contingency plan for how we're actually going to look at the data collection for the next 12 months, and how we're really going to look at bringing new people online who are going to help us with that. And so certainly I'm sure myself and the other national leads will be very keen to help our hospital leads to do this. And that will be a challenge, because many of our hospital leads are junior doctors and you're about to move on to your new rotations.
And I think, Amanda, what are your thoughts in terms of a future trial within GECKO? Would there be interest within Australia in terms of what Ewan has spoke about?
Yeah, I think so, Savesh. I think there is a great deal of promise. I've really liked the concept of the critical view of safety that we've outlined as part of the GECKO trial, and having that time out intraoperatively for us to actually review where we are with the critical view with the difficult cases, I think has been really useful. And I know certainly locally, it's been fantastic for our trainees to actually consider what constitutes a critical view, and what the steps are that are necessary for a safe cholecystectomy. And I think GECKO's actually been very helpful in that respect, and there's a lot of learning opportunities to improve our safety for cholecystectomy.
And Maria, I'm not sure if you're on the call at the moment to sort of have your
Yes, here. Yes, hello, Sivesh. Here I am. First, I want to start by thanking the team for the amazing work that has been done. It was an amazing collaborative, and the numbers are wonderful. So very well done. I also wanted to highlight that it's great that you were able to choose a very nice common surgical procedure, and the idea of a future study involving an educational intervention like the one that was used in Eagle is something that it's really appealing for us. I would say it's going to be something important because it includes implementing something simple that can have a huge or a great impact in reducing complications. So just participating in the GECKO study has been amazing as for everybody, even not only the trainees, but also the consultants. We were able to, because we do all these things, but we usually don't pause and separate our thought in the different steps. So this has helped us to do that. And I think that educational intervention would be a very nice tool to try out to see if we can have reduce complications just by doing that.
Thank you. And I think more from a logistic perspective from everyone who's here in terms of data validation and some of the hospital leads who are here as a national leads perspective, what are your thoughts from data validation? Have you had much questions that you like to share or issues that have come up that Renu and all of us can help with? Because it's quite a nice forum to have everyone in the room here to sort of discuss some of the day-to-day issues that you have probably encountered preceding this.
Yeah, so I think that the questions that we have for data validation were answered today. So most of them were about how to identify the patients and how to make sure that we are really validating the one that we the same patient that. So I think that the explanations that we received today were clear enough, and so I hope we don't have any more issues than the ones that were addressed today. I really don't have any other question.
And we've got Amanda and then Renu.
Thanks, Savesh. Some of our hospital leads have asked whether they could actually be a validator if they haven't been involved in data collection. Are they considered independent enough to be able to do that?
I'm going to pass it on to Renu, who's also got a hand up. So
sorry, did you say the hospital lead?
Yes.
No,
if they haven't been involved in data collection themselves, can they be a data validator?
But the no short answer, because they have full access to the original data on RedCap, because hospital leads have access to the data set. Also, they've been emailed the patient summary tables. So basically, even if they didn't enter any data, they have been involved in the primary data collection.
Okay.
Yeah. It's a really good question, though, and it does come up. I would like to answer a question, a very good question that was typed in by someone asking about country level analysis, and would it be possible to make country level information available for hospital leads? we understand that this would be hugely beneficial to do like your country audit. As per data approvals and permissions, we're not allowed to share one hospital data with another hospital from the same country. But how this works, if you want to do hospital level, country level analysis, you need to write to all of the hospital leads, and those are listed. You have the contacts to the other hospital leads within your country, and every hospital lead will then explicitly share their data with well, you will have to agree amongst yourselves who will summarize, collect and summarize all of the data. But basically, hospitals need to come together and share data with each other. We here in Edinburgh or Birmingham are not allowed to share your data with other hospitals. Hope that makes sense. Let me check. Yeah, any other questions, anyone? I'll check the...
Men nu kommer jag inte ihåg vad vi gjorde för plan för men...
Sorry, Gabriel, did you want to come in there? I can't see access to chat, but has anyone else got any other questions that they would like to raise as a hospital leader or national leads? I think we've got everyone here to sort of ask any issues that you might have that we can help answer. Can't see any comments coming through at the moment.
Nida Wahid has asked that their validator will require help from the surgical team for data retrieval, as our patient medical records and operation theatre data is not accessible to all. I guess, Rini, what do you think about that?
It's a tricky one.
Because that is quite tricky, isn't it? Because with the surgical team, as long as if they haven't contributed to data collection, would that be okay?
Well, but then the surgical team would be asking, am I the validator? I think the hospital lead can use their judgment on how this access. I can understand that access issues, there are only so many computer logins on certain computers, but if you could lead the validator to access, but then let them count up the patients on their own. Do not point them at the variable and say, this is the patient and this is that. You know, that's not independent validation. But if you need to unlock a door for them or log into a computer, that's okay. I hope that's all you need.
Yeah, that is quite a tricky one. Thanks, Renu. You were about to come in there before we had that question.
Yeah, I mean, I'll say two things. I'll answer one of the questions and make another point. It's important to get across to your teams that validation is not a punitive process. It's simply us trying to understand exactly how good the data collection has been. But nobody's going to be excluded. No one's going, we're not going to be telling anybody the results of that or anything. So it's what we really want is an unbiased estimate of the validation. So we don't want validators uncovering cholecystectomies that in error haven't been included. We just want them to be upfront and tell us that. We did a study before in our own hospital, and it transpired that some of the patients in day surgery hadn't been included because the team hadn't anticipated that that particular procedure was being done there. So it's that sort of thing, but it's not punitive. There is no consequence to either there being inaccuracy in the variables or there being patients who haven't been included. So the second thing I was going...
Oh, sorry.
Yeah, go on. Well, the second thing I was going to say was, I think Peter was asking in the chat, will part of the study write-up involve sub-analysis of different countries? So there was a famous publication in The Lancet in 2012 called Mortality After Surgery in Europe, a 7-day study. And it was one of the first international collaborative studies that was done. And in that, country-level analysis was done probably without sufficient involvement of country-level investigators. And there was an amazing outcry, a huge outcry, with letters written by collaborators to The Lancet complaining about the patient, complaining about the publication that they had been authors on. And the underlying problem was that if you look at differences in, say, outcome across different hospitals or across different countries, then you will likely show differences in that. Someone will be best and someone will be worst. But in this sort of study, where we haven't been consciously, randomly sampling the whole of a country's surgical practice, we can't draw conclusions as to potential differences in outcomes at the level of the country. So it would be incorrect to do so. And so on the basis of that, for all of the studies that we've done, we have suggested to collaborators that we don't publish summary statistics or outcomes at the country level, because it's not particularly meaningful to do that, and can understandably cause a lot of upset because you end up with this rank of outcomes.
Thank you, Ewan. I think that's a really important point to make. I think we're here to try and understand what the outcomes are and to try and improve the understanding and knowledge as a surgical community. And we're not here to sort of point out who made flaws. I think the other question maybe for Reno or Ewan, in terms of missing data, there's generally a worry amongst collaborators or hospital leads as we went through the data chasing and as we enter data validation. In terms of the level of missingness, and if there is a threshold that people would be discounted for, is there any particular standards that we're setting, or are we just saying to people just to come forward with whatever that's going on, and we welcome them with open hands?
The standard was predefined in the protocol, so yes. It's quite complicated when I say it now, so heads up, a complicated sentence. 90% of the patients need to be 95% complete. But don't worry about doing that calculation on your own. Sivesh will email you if that is not the case for your hospital.
And I think there is just another question, Renu, about, validators need to be completely independent, and there's someone asking about, can the hospital leads be copied into the emails when we issue data validators? Is that something that we are planning to do, or are we going to be completely independent with that?
I think it's fine to notify the hospital leads that the account has been created in case it goes into spam or something like that. Similarly to the process with collaborators. But yeah, they should not be included in communications about data points. Yeah, good, yeah. Very good point.
And I guess we probably, in terms of hospital level analysis, a lot of collaborators over the last week or so have been asking, would they be able to get their own hospital level feedback in terms of outcomes and stuff compared to the global rates? Is that something that we would want to be doing for the hospital leads, or is that something that we should be doing for them?
Oh, very good question. Love it. Easy answer. So basic reporting is built into RedCap. So if the hospital lead logs into RedCap and clicks on reports, and then there's a button that says charts and statistics. So if you click on charts and statistics, RedCap will automatically give you bar plots for your outcomes, for your patients, kind of age, sex. You can even create further plots on RedCap directly. So yes, please use the RedCap's built-in reports page.
Thanks, Rena. And I think another question is about, a lot of people keep asking if they can be validators when they've been hospital leads or national leads. Now, is there going to be a way that some of the registered validators will not get actually logins for their centers if they're also detected to be a hospital and national lead? Is there going to be a system in place?
Yes. So we will check that the validator was not part of the original data collection team. If they were, they cannot be the validator. We will email the hospital leads to let know we've noticed that this person is not independent. There's a good question in chat about what happens to a center that they do not achieve 90% of ascertainment. If it comes out in validation, then as Ewan said, nothing happens. They will remain in the study. It happened in our very own hospital that our team had not considered a group of day patients, and the validator just pointed it out. That is fine. We will summarize this and we will report this in the paper and say the average ascertainment across all our hospitals is whatever percent. In Global SOS 3 was 96%, but we will not remove anyone. because if we started removing centers, we wouldn't know whether others are just not reporting it, or so validation will never remove any center or patient based on accuracy or ascertainment. It is only used to inform the readers of our manuscripts, really. I hope that answers that. If, however, you ignore or fail to fulfill Sivesh's pre-validation emails, so if pre-validation your data is already noticed to be incomplete, then you may be excluded from authorship. Having just said that, that only affects a very small number of people who have received multiple emails to be notified. So if your data goes into validation, your data is definitely included in authorship and analysis. The recording will be sent out to everyone. If hospital lead is a lone validator. So hospital lead has access to the original data set, therefore they can't be the validator.
Thanks, Rina. So I think key for everyone is that please make sure that your data is as complete as as possibly can by this weekend. I think it's really key that we're locking the database on Monday, and then data validation kicks in. So please ensure that you've got your validators in place, and we will send this recording out so you can listen and send it to your validators to ensure that they get the process right. And I think as you, Natalie and Ewan had suggested, I think the 1 year follow-up is something very unique, but in process, we'll start thinking about what the first paper might look like, and then we will share this analysis out with you, and we will keep regular updates throughout the process as we come into 1 year follow-up and think about the future trial. Has anyone else on the panelists speakers got any final comments or final closing words before we draw this meeting to a close? Amanda and Maria?
No, thank you very much, Sivesh. Just to thank you for your leadership for this study.
Thank you, Amanda. And Ewan, Renu, final remarks before we close this session and then convene in the 5 p.m. session?
Not from me. Thank you again to everyone.
Thank you, everyone. So I hope everyone's found that really useful. It's been really interactive, and hope everyone's got something out of it. So we'll draw that to a close, and we'll see. We'll have the next one at 5 p.m. So hopefully we'll have a new batch of hospital leads and national leads join. So thank you, everyone. I hope you have a good morning, afternoon, lunch, and evening, and see you.